Good morning, everyone, and welcome to Heart Center Grand Rounds. I'm very pleased to have with me today Dr. John Mahmarian. And before I introduce Dr. Mahmarian, just a few housekeeping things. First off, I want to make sure everyone is staying healthy and staying safe. And we're doing our part here to practice social distancing by televising these Grand Rounds virtually. For those folks that are tuned in via live stream, Facebook, or YouTube, if you have any questions, you can either text the number 37607 and text DeBakey to that number, or you can go to pollev.com and enter the code DeBakey, and that'll allow you to enter in any questions that you may have, and we'll certainly save some time at the end for some questions. So today's speaker is Dr. John Mahmarian, who really needs no introduction. John is our Director of Nuclear Cardiology and Cardiac CT here at Houston Methodist. John is really internationally renowned in both nuclear and cardiac CT, being a past president of the American Society of Nuclear Cardiology. John comes to Houston from New York, where he went to medical school a few years ago, but then he's done all of his training, internal medicine, cardiology, here at Houston at Baylor College of Medicine, and has been really here at Houston Methodist pioneering both nuclear cardiology and cardiac CT. John, I think, as we'll see today, is a tremendous speaker. He's very passionate about this field, and he's going to give us some insights into predicting risk and guiding therapeutic decision making in stable coronary artery disease. And he's going to talk to us a little bit about has the ischemia trial caused a paradigm shift or not. John, welcome.
Great. So thanks very much, Dipan. Thank you, everyone, for joining in. Yeah, I'm going to talk about this whole issue of guiding therapeutics and risk stratification. And it's really a trip down memory lane because this has been going on for the last 30 years or so. So first of all, we have to understand the patient population at risk with coronary atherosclerosis. And I want to emphasize, first of all, that most people actually with coronary atherosclerosis are asymptomatic, and that the symptomatic group represents a real small minority. And as we talk about the ischemia trial population is really the tip of the iceberg. It's the smallest group of people that we actually study who have coronary atherosclerosis. I also want to emphasize one other issue about the ischemia trial, because it used ischemia actually as a method for enrolling patients, that over the years, ischemia has actually dramatically decreased. These are data from Rosansky showing that some 40% of patients had abnormal myocardial perfusion exposure, inexpensive, and identifies plaque better than any other technique we have available in terms of comparing to functional imaging. Now, you might ask, why not use functional imaging to assess patients who are minimally symptomatic or asymptomatic? And actually, there are good data, both from Zellweger and also from our data here with Dr. Chang, showing that actually myocardial perfusion imaging does predict risk based on the amount of ischemia. People with small amounts of ischemia have very low risk for events, and patients with large amounts of ischemia, particularly when over greater than 10% of the left ventricle at high risk. But as you can see, very few people actually have ischemia in terms of the asymptomatic population. So you're screening a tremendous amount of patients to find a very small percentage who are at risk. And the other issue is that myocardial perfusion scans only predict short-term risk. They don't predict long-term risk. And this is probably because stress imaging does not identify early atherosclerosis. So let's look at the data in terms of calcium scoring. These are data from MESA. The median follow-up in this study was 11 years. We're out to now 4 years. And what have we shown in all of this? If you have a calcium score of 0, you have an incredibly low risk of cardiac events. And you can see the red dashed line is a 7.5% event rate at 10 years. You can see that calcium score of 0, almost every single group has a risk less than that at 10 years. So the power of 0 has been talked about for a long time, and it allows us to find people who really can avoid having use of statin therapy, etc., because their long-term risk is incredibly low. If you look at patients, however, who have more than calcium scores of 0, and in fact particularly high scores of over 300, you can see that in both women and in men the risk increases dramatically. But the important thing to pick up here is that there is a lag in terms of when you identify someone with a high calcium score and when event rates start to arise. And we look at this as a window of opportunity to treat, finding patients first and hopefully impacting upon risk by treating patients very early on before they would be expected to have a cardiac event. And in fact, there's a lot of good data, and you all know the statin data in terms of reducing risk, but there's actually data with serial CT imaging, this being one of the first ones in JACC imaging in 2010, showing that you can significantly reduce low attenuation plaque when you look at statin therapy versus no statin therapy in patients who have serial CTAs. This study was over a 1-year follow-up period. But now there are 6 studies total that have looked at serial CT showing regression of low attenuation plaque, which is thought to be the culprit for cardiac events with the use of statins. So by treating patients very early with high calcium scores, the whole idea here is to potentially impact long-term risk and avoid developing ischemia and avoid developing cardiac events. That doesn't mean there isn't a role for myocardial perfusion imaging. And in fact, if you look at these data comparing myocardial perfusion imaging versus calcium score results, first of all, you'll see that patients with low calcium scores have very low risk of having an abnormal myocardial perfusion scan. But in the 10% of patients with calcium scores over 400, there's about a 25 to 30% risk of having myocardial ischemia. And this is also about 10 to 15% in the patients with intermediate calcium scores. Now, we don't have categorical data on terms of whether treating patients with anti-ischemic therapies or revascularization improves outcome in the asymptomatic population with ischemia, but we think that is the case. And I can tell you that in terms of guidelines, what is now recommended is that in patients who have calcium scores over 100, that stress myocardial perfusion imaging performed. Now, the only real trial that has looked at the asymptomatic population was actually a trial that we were involved with many years ago called the Asymptomatic Cardiac Ischemia Pilot Study. And in this study, we actually enrolled patients who had both symptomatic and asymptomatic ischemia, but most people actually had asymptomatic ischemia. And we guided therapy by just treating angina alone, treating ischemia alone by ridding the patients of any kind of evidence of ischemia by looking at ambulatory ECG monitoring or performing revascularization. And what you can see in these results in terms of death and MI, there is a trend toward a reduction in event rates as you go from angina-guided to ischemia-guided to revascularization strategies. And this is also true for death MI and subsequent revascularization, where revascularization seemed to do a better job. So I think there is an important concept here in terms of where we stand in terms of treating aggressive ischemia, whether it be with medical therapy or revascularization, and even asymptomatic ischemia is something we need to be concerned about. Now let's turn our attention to the symptomatic patient with known or suspected coronary artery disease. And I think there are several things to recognize here. First, we want to identify patients unlikely to benefit from an interventional approach. Those would be low-risk patients with no ischemia by functional testing, or normal coronary arteries or non-obstructive coronary disease by either invasive coronary angiography or cardiac CTA. There would also be those higher risk patients who maybe have coronary disease but have no significant ischemia. That group has also been shown not to benefit from a revascularization approach. But there are certain populations that probably do actually benefit from some kind of very intensive therapy. And those would be patients who have ischemia, and in that group population, both anti-ischemic medical therapies and interventional approaches might be the best ones to target in terms of having enhanced benefit. And so the questions are, how can we assess initial risk and track risk, potentially with the kind of testing modalities we have, and then decide what our therapeutic outcomes will be in terms of decreasing cardiac events, improving quality of life, and also deciding on what therapeutics are best, whether it be a combination of interventional approaches in medical therapy or medical therapy alone. So let's talk a little bit about ischemia. Even 20 years ago, we recognized the importance of myocardial ischemia. And these are actually data from the European Coronary Artery Study with 12-year follow-up looking at patients who either had revascularization or medical therapy. And you can see that in patients with baseline no ischemia or no ischemia after they were randomized, these patients had no different effect in terms of surgery versus medical therapy. If you look at patients with a positive treadmill test, these patients did better with surgery than they did with medical therapy. And patients who had markedly positive treadmill tests, very early onset ischemia in the first stage of the Bruce protocol, etc., those patients did the best with surgery versus medical therapy. Now remember, this is back when medical therapy was basically placebo. Okay, so whether you can translate these data in terms of the differences in treatment algorithms today is a different issue, but it just shows you how the importance of ischemia is in terms of predicting out those high-risk populations, irrespective of initial anatomy. These are data from the CACS registry, again, many years ago, showing the value of identifying ischemia after revascularization was performed, in this case, CABG. And you can see in group 3, in patients who had no ST depression or angina after CABG, they had the best outcome. But look at the group who had both ST segment depression and angina after CABG. You can see they had the worst outcome despite revascularization. If they had residual ischemia, they did very poorly. So ischemia is important not only from initially identifying risk, but also tracking risk. These are another data from Bob Bonau group that was published back in 1984, looking at patients with multi-vessel disease primarily, who were actually assessed with exercise-gated radionuclide angiography, or as we used to say, a MUGA study. And in this population, you can see from an anatomical basis that patients with triple vessel disease did worse in terms of survival than patients with single or double vessel disease. But look at the patients with triple vessel disease who had a normal exercise response and an increase in ejection fraction on gated radionuclide angiography. Those patients had no mortality. Whereas in comparison, those who dropped their ejection fraction or had ST segment depression were the ones who died. And this is particularly true in patients who not only had triple vessel disease and not only a drop in EF, but had a drop in EF at a very low exercise capacity. So functional testing can be extremely important in teasing out which patients with multi-vessel disease are the ones who benefit most from revascularization procedures. This has also been shown with myocardial perfusion studies looking at the amount of ischemia and whether studies are normal or abnormal. We've known for decades now that a normal myocardial perfusion scan is a gatekeeper to the invasive coronary angiography, to the cath lab, and in terms of guiding management, such that in patients with a normal myocardial perfusion scan, the risk of death or MI is about 0.5% per year. And we know there's a 10-fold increase in that event rate if patients have an abnormal myocardial perfusion scan when you look at death or acute myocardial infarction. There's also a gradient in terms of risk. These are data from the INSPIRE study, a post-MI study that we published back in 2006, looking at the value of knowing perfusion defect size and ischemic defect size in terms of predicting total cardiac events and death and MI. And what you can see here, there appears to be an inflection point where after the defect size goes above 20%, we see an exponential rise in cardiac events and death and MI. And when ischemia goes above 10%, we see an inflection point there where you can see an exponential rise in cardiac events and death and MI. So these are some of the first data to show not only an inflection point, but the fact that there's an exponential rise as you get into higher degrees of perfusion abnormalities and ischemia. This has also been shown in the PET data, and these are data from Dorbola on the left looking at cardiac death in terms of the amount of abnormal myocardium that's abnormally perfused. And you can see that as the size of the perfusion defect increases above 20%, you see a dramatic increase in event rates. And in the ischemia aspect of this trial, for every 34, there was a 34% increase in cardiac death for every 10% increase in ischemic myocardium. On the right side of the slide, you can see another analysis by Dorbola looking at gender in terms of cardiac death. And the first shows men, and this is again looking at the amount of abnormal myocardium. And you can see above about a 10 to 20% perfusion defect size, you start to see this exponential rise in event rates. And this was also shown in women at the same level of perfusion defect size. And these data are very much the same as what I just showed you in the INSPIRE study. Very complementary data confirming the importance of defect size and the exponential increase in event rates with perfusion abnormalities. The problem with other kinds of techniques, and I'm going to talk a little bit about cardiac CT, is that you really can't assess ischemia with cardiac CT. It's a very cumbersome technique and it leads to very high radiation exposures. And it's really important to know the size of abnormality of the perfusion defect because we showed 20 or 30 years ago, back in 1991, that you cannot tell by anatomy alone how much jeopardized myocardium is supplied by any given artery. You can only tell that by looking at perfusion defects in a given patient. Now, moving on, there's also been more data to show us how PET studies can be important. And this is particularly looking at coronary flow reserve, a way of looking at not only the entire epicardial bed, but also the subendocardium and the microvasculature. And what you'll see here are different types of patients. Here you can see event rates in patients in red who had no coronary disease but diabetes, but had a low coronary flow reserve. And in blue, people who had no coronary disease and diabetes but had a high coronary flow reserve. And you can see there was a marked reduction just based on coronary flow reserve in who had cardiac mortality in this particular trial. What's also interesting is that if you look at people with coronary artery disease and diabetes, they were the same as people who had no coronary disease and a low coronary flow reserve. Okay, so coronary flow reserve was an incredibly important predictor of cardiac events and something we can very easily now calculate and monitor. So beyond perfusion and beyond ejection fraction in this study, the most important predictor was coronary flow reserve in terms of the entirety of the abnormalities in the microvascular. Now, in terms of CTA, we also have very important information from there, and we know that in people with normal coronary arteries by cardiac CTA, which in the confirmed study represented actually most patients, you can see that the event rates are extremely low. But as you go from non-obstructive to multivessel disease, particularly triple vessel disease, you can see an increase in event rates. So mortality significant increase in this study based on extent and severity of atherosclerotic plaque. We also know there are comparative studies. This is the PROMISE study in some 10,000 patients comparing functional testing to cardiac CTA imaging in terms of anatomic testing, showing over a 42-month follow-up period, there was no difference in terms of event rates when patients were assessed with functional testing versus anatomic testing. But what was interesting in this study was that in the CTA group, more patients ended up in the cath lab compared to the functional testing group, and there was twice as much revascularization in the CTA arm than in the functional testing arm, and yet there was no difference in outcome. This not only has important implications in terms of the use of functional testing versus an anatomic test, where you actually know the anatomy and it may bias you in terms of doing invasive coronary angiography and revascularization, but also has implications in studies like the Ischemia trial in terms of does revascularization in low-risk patients who are otherwise doing well really improve outcome? And in PROMISE, the answer would be no. Now, there are some issues in terms of the appropriateness of, let's say, CTA, though. And this is data from the SCOT-HEART trial, which actually, similar to the PROMISE study, looked at functional testing versus anatomic testing. But in this trial, treadmill testing was the only modality used, not myocardial perfusion imaging or other imaging modalities. And what you can see here is that when you look at death or non-fatal MI, in terms of overall outcome over 5 years, the standard of care group had more events than the CTA group. In fact, the hazard ratio was 0.59 if patients were randomized to CTA. Now, we recognize that CTA in itself has no intrinsic value in terms of reducing cardiac events. And you'll also notice that the revascularization in this study was the same in the two populations. But treatment changes were different. And the CTA group, by identifying plaque, more patients were treated with antiplatelet drugs, statins, and ACE inhibitors compared to the standard of care group. And it's thought, at least in this trial, that the increase in use of anti-ischemic medications was the pivotal reason why event rates were lower in the CTA group. There's also these data from Hulton showing that in patients with moderate coronary artery disease by CTA, that by using statins, you have a much lower event rate as compared to patients who are not treated with statins. And these are data from the CONFIRM study, looking at patients with non-obstructive coronary artery disease versus normal coronary arteries based on a CTA estimation. And what you can see in people with normal coronary arteries, whether patients were on statins or not, it made no difference in terms of over a 2 to 3 year follow-up period. But in patients with non-obstructive, this is not patients with single, double, or triple vessel disease, greater than 50%. These are patients with non-obstructive disease. You can see the value of statins in terms of reducing cardiac events over a relatively short follow-up period. So the concept has become that one of the strengths of cardiac CTE is to really identify patients with normal coronaries who really don't need treatment, and also identify patients who have non-obstructive disease at an earlier stage than you can with functional testing in order to identify those at low risk, or at higher risk who might benefit from statin therapy. Now, another interesting finding from SCOT-HEART was they looked actually at plaque predictors. And we know that stenosis severity, positive remodeling, low attenuation plaque, and the napkin ring sign, which I've hardly ever seen in CT, but is something that's described a lot, are important predictors of risk. But in SCOT-HEART, they also looked at the calcium score. And what they found, when you look at all the adverse kind of plaques, obstructive coronary disease, cardiovascular risk scores, that the simple calcium score was the best predictor of events. And so we really need to get away from the concept of the vulnerable plaque and really talk more about the issue of the vulnerable patient. And the vulnerable patient is best identified by calcium scoring, looking at those who have extensive coronary disease versus less extensive coronary disease. Now, if calcium scoring is really that good, then maybe we could actually apply calcium scoring to functional testing to better identify risk and who needs therapy. So these are very intriguing data from Engbers, published in 2016, looking at some 5,000 symptomatic patients with suspected coronary disease who both had SPECT and calcium scoring. You can see there was a high prevalence in terms of intermediate risk for coronary artery disease. And you can see that in this particular study, as the calcium score went up, you were more likely to see an abnormal myocardial perfusion scan. This has been shown time and time again in multiple studies. So here you can see very low positivity of SPECT studies in patients with calcium scores of 0 as compared to patients with calcium scores over 1,000. What's important about this study is in the patients with a normal myocardial perfusion scan, 69% of those patients had a calcium score greater than 0, 15% had a calcium score over 400, and 6% had a calcium score over 1,000. Now, when you look at outcome in people with normal SPECT versus abnormal SPECT, you can see that in patients, irrespective of the perfusion results, if you had a calcium score of 0, you had a comparably low event rate. But look at the increase in events, particularly in patients who had a calcium score over, in patients who had an abnormal myocardial perfusion scan and a calcium score that was over 1,000. You can see a dramatic increase in cardiac events. And so in the overall population with normal SPECT, calcium scoring was the best predictor of risk. But in the patients with abnormal SPECT, there was an integration of both calcium scoring and the size of the perfusion abnormality to better identify and tease out the higher risk populations and the lower risk populations. So there's this value of integrating calcium scoring with perfusion imaging, and you don't need CTA to do that. We have also published data with Dr. Chang showing at over a 10-year follow-up period the value of calcium scoring in patients with a normal SPECT. This was a natural history study, so patients weren't necessarily treated with statins or any other kind of medical therapy per se. And what you can see is that in patients with a severe calcium score, despite a normal myocardial perfusion scan, event rates started to increase around 3 to 4 years after the initial myocardial perfusion scan was performed. So SPECT has a very short warranty period of only 3 to 4 years, and calcium score helps identify patients at early risk. And again, we talked about this window of opportunity in terms of identifying patients who may be at short-term risk, but they have calcium, so they should be treated aggressively because their long-term risk may be significantly affected. And so the idea is to target individual patients with statins and other medications based on their calcium score, even though they may have normal myocardial perfusion scans, in order to improve potential long-term outcome. Now, this is a study in a patient who actually had multiple risk factors. Kind of look at this more objectively. This patient went for a PET study. He had multiple risk factors. He had some non-specific atypical chest pain. You can see the PET study is entirely normal. We also looked at coronary flow reserve, and you can look at the rest flow and the stress flow, and the reserve was over 2 in all vascular territories. So by all definitions, based on what I've already told you about coronary flow reserve, this would be a low-risk patient based on perfusion and also flow reserve. And the ejection fraction was also normal. But this patient had a calcium score of almost 2,000. So although the short-term risk is low for this patient needs to be aggressively treated. Now, I've showed you some of the benefits of why maybe coronary CTA would be worthwhile. And we do this all day long. This is in patients with suspected coronary disease. If you have a normal study, you can reassure patients. If you have non-calcified plaque, statins are appropriate as well as aspirin therapy. If you have patients with significant or intermediate stenosis, again, medical therapy and borderline stenosis, we usually do either coronary flow reserve by CT or functional testing. But then we have this population, those who have extreme calcium and where a functional testing is really important. And this is the group that for myself and all our readers, we use Visine and Tylenol because we get so tired of looking at these intensely abnormal images. And unfortunately, the problem is that as you go from low-risk patients up to high-risk patients, that those studies on the right are the most common to be seen. And that's also the group that was more commonly seen in the ischemia trial. One of the reasons why CT should not be first line in patients that are high risk, and why in patients with known disease we don't use CT as a first line test. So to kind of look at the final issues here, we have the 800-pound gorilla in the room. How do we decide who should get medical therapy, who should be revascularized, and what does the data show? First of all, we already know that patients with left main disease and those with extensive coronary artery disease and who have low EFs do better with revascularization than with medical therapy. And I want to just show this. This is the STITCH trial that was published several years ago, looking at patients with ejection fractions less than 35%, but had coronary disease amenable to bypass surgery. And in this study, patients were randomized either to medical therapy or to bypass. And this is looking at the long-term results in terms of 10-year outcomes. And what you can see here is that actually in the early period, medical therapy actually did better than bypass surgery because of a higher event rate due to the bypass procedure itself. But after that time, after about 2 to 3 years, we see a divergence in the curves. And we see that bypass surgery actually does better in terms of long-term as compared to medical therapy. And in fact, when you look at the number needed to treat to prevent one death over a 10-year period, only 14 patients would need to be treated with bypass surgery versus medical therapy to prevent one death. 11 patients, 11 patients would need to be treated to prevent one cardiovascular death, bypass surgery versus medical therapy. And when you look at any all-cause death or cardiovascular hospitalizations, you'd only have to treat 9 patients to prevent one event with bypass surgery versus medical therapy. So I think it's pretty categorical that when we think about very high-risk patients, that medical therapy really doesn't fit into that category, that it's really those that in that population, bypass surgery is a much better option. And this was also seen when you look at all different subsets in the STITCH trial, particularly again in those with triple vessel disease and low ejection fractions. But that's not to say medical therapy isn't good. And in fact, there are multiple trials, for instance, looking at PET imaging, showing how lifestyle modifications, how different medications, beta blockers, nitrates, actually reduce perfusion abnormalities in serial PET imaging. And there's also many data looking at serial SPECT imaging showing how beta blockers, nitrates, lifestyle modifications, statin use, combination anti-ischemic drugs, and even some trials looking at angiogenesis factors when they were in vogue, showing reductions in myocardial perfusion scans on serial imaging using SPECT imaging. So we have a lot of data showing that medical therapy can reduce myocardial ischemia or inducible myocardial ischemia. This is an example of a patient of mine for several years ago who actually had symptoms of angina. He had a rather large perfusion defect of 26% involving the septum, which can clearly be seen in this image with improvement on the rest images showing a tremendous amount of ischemia as shown in green. The patient was actually found to have isolated septal disease, isolated first septal disease, and it was diffuse, and of course, there was no way to intervene on this patient except with medication. So the patient received nitrates and beta blockers and then came back for a second study and came back with this. Almost an entirely normal study with the use of simply using medical therapy, serial imaging with SPECT imaging. Okay? This is another study we did several years ago where we actually looked at the use of smoking cessation in patients who had smoked at least 1 pack per day on myocardial perfusion defects in patients who had documented coronary artery disease. And this is just an example of a patient who had ischemia of 26% on the first study while smoking 1.5 packs per day of cigarettes. And then this patient went on a nitroglycerin patch and actually stopped smoking entirely during the several-week follow-up period and came back for a second exercise myocardial perfusion scan. And this study showed now almost complete resolution of ischemia. So there are many ways in which we can see, using serial imaging, how medical therapy would work. Now, if I were to show you these studies, and say, what do you think the patient received? You would say, well, obviously the patient got revascularized. Patient received angioplasty, patient got bypassed. No. This is simply medical therapy and showing the effectiveness of medical therapy on myocardial perfusion. Now you might ask, where has that also been shown? Well, actually in the COURAGE trial, which looked at angioplasty versus medical therapy, there's actually data from Leslie Shah showing how effective medical therapy can be. And in this particular trial, in patients who receive medical therapy, you can see a marked reduction in individual patients in terms of total defect size, pre-therapy versus 6 to 18 months later. And this is shown with both medical therapy and with angioplasty. Medical therapy on the right, angioplasty on the left. But you can see that the effects, although the effects were a little bit greater with angioplasty versus medical therapy, it was really variable. Some people with angioplasty actually saw an increase in perfusion defect size on serial imaging, and that was also true in medical therapy. So it's very hard to predict who will respond to a different medical therapy, but both kinds of therapy can reduce ischemic burden. And if you look at the results in terms of subsequent imaging, you can see that if you look at patients who had no residual ischemia, irrespective of the methodology, those patients had the lowest, had basically no events in follow-up. And as residual ischemic defect size increased on the second scan, you can see that event rates continued to increase dramatically. And so one of the issues that has been proposed is to potentially reassess therapy by the use of serial imaging to assess who has actually been effectively treated and who has not, because it appears, as I already showed you from many years ago from the CACS registry and some of the earlier bypass studies, that patients with residual ischemia, despite therapy, if they have residual ischemia, they tend to do worse. Now, we also looked at this in a post-MI study. This is the INSPIRE study, and I'm not going to go through a lot of the different aspects, except this is a stable patient group post-MI. But we did something very unique in this study. We took high-risk patients with large ischemic perfusion defects, importantly, who had ejection fractions greater than 35%, and then we randomized them to a very intensive medical therapy versus revascularization plus medical therapy. We did a second SPEC study at 1 month, and we followed them up for a year. And what we were able to show in this trial is that medical therapy was just as effective as revascularization at reducing total defect size, ischemic defect size, and when we look at the number of patients who had an individual response, more than a 9% decrease in total or ischemic defect size, which is the cutoff point for a real change versus not a real change, you can see that most patients in both groups had a significant reduction in ischemic or total defect size. Now, this would also be thought to be highly unlikely, medical therapy versus revascularization. And when you look at the results of INSPIRE, there was no difference in this population in terms of one-year outcomes, revascularization versus medical therapy. Now, INSPIRE came out in 2006, but COURAGE came out in 2007 and showed the same thing with PCI versus medical therapy. And in 2009, the Barry study came out, again showing no benefit of revascularization versus medical therapy in diabetic patients who are stable. But what was interesting in Barry is there actually was a two-stratum. Those patients who either were randomized to medical therapy versus PCI or medical therapy versus CABG. And you can see in the PCI versus medical therapy group there was no difference, but there was benefit in those randomized to revascularization with CABG versus medical therapy. So this was the first trial to show maybe the benefit of CABG in diabetics. And since that time, there's been the FREEDOM study, which actually randomized patients with CABG versus PCI. And in this trial, in 1,900 patients, you can see that CABG did better than PCI. And when you look at the 10-year and when you look at the 10-year results, this held up. And this is looking at the 10-year results in terms of death on the right-hand side from this trial as compared to the 5-year results. So irrespective, it appears in the FREEDOM study that bypass surgery appears to be a better option in diabetic patients and in patients with multivessel disease with diabetes than medical therapy. And again, you can see the event rates here were significantly lower in the PCI group versus the CABG group over a 10-year follow-up period. Now, what about FAME? FAME is an interesting study, and again, it brings up the idea of physiology matters. And in FAME, the FAME-2 trial actually compared medical therapy versus revascularization. And this was in almost 900 patients. Revascularization was guided by FFR in terms of patients with a less than 0.8 FFR were randomized to optimal medical therapy versus PCI. And what's interesting about FAME is that when you look at the primary endpoint, absolutely medical therapy lost. But when you look at death or revascularization, such as myocardial infarction, there was no difference. The only difference was in urgent revascularization. And what's interesting here is that it appears that urgent revascularization, this sort of a nebulous term, did not lead to an increase in myocardial infarction. Because if you look at the myocardial infarction rate, it was stable across the entire follow-up period, despite the fact that urgent revascularization increased. And I don't think this is surprising, because we know that medical therapy can be effective. And we know that PCI to specific vascular beds may not identify patients with large ischemic burdens where maybe medical therapy might still be as effective as revascularization procedures. In terms of meta-analyses, this is one that was published just recently, taking all of these studies into account. And when you look at death, when you look at non-fatal MI, when you look at unplanned revascularization, and when you look at angina follow-up, the only issue that may be contentious is that there are more potentially unplanned revascularizations in these different trials, medical therapy versus revascularization. But in terms of all of these other endpoints, by meta-analysis, no different. So then we get to the issue of the ischemia trial. And I want to spend the last few minutes talking about that, because the ischemia trial was really based on these data by Dan Berman's group, showing that somewhere around a 10% ischemic threshold is where we start to see an increase in events with medical therapy as compared to revascularization. What's interesting about the ischemia trial, it didn't really look at people who had less than 10% ischemia. It included only people with greater than 10% ischemia. And one of the issues with the ischemia trial is that there are still no data whether patients with increasing perfusion defect sizes did better with revascularization or medical therapy. It's just whether they had more than 10% ischemia or didn't. So that's an important issue as we talk further. There's now data with PET imaging showing the same thing from Dan Berman, showing that from Tim Bateman, showing that around 5 to 10% ischemia is where you see an increased benefit with revascularization compared to medical therapy. So we have two trials separated by about 20 years, one with SPECT imaging and one with PET imaging, showing improvement in outcomes when you get into higher degrees of ischemia with revascularization versus medical therapy. And there's also data by Tim Bateman showing the benefit of coronary flow reserve, showing that as coronary flow reserve goes down, you see an increase in event rates. This is irrespective of ischemic burden, as you can see here. And I just want to emphasize that there's a lot of diversity across ischemic groups in terms of what coronary flow reserve results are, but coronary flow reserve in this study was shown to be the dramatic reason for defining events and no events. And again, if you look at a model looking at medical therapy versus revascularization, somewhere around a coronary flow reserve cut point of 1.8 is where you see benefit with revascularization versus medical therapy. So all this seems to be rather consistent. And again, in this trial, ischemia wasn't so much of an important predictor. So let's get to ischemia trial. Ischemia looked at patients who had moderate to severe ischemia. They had a blinded CTA to eliminate either no disease or left main disease, which was evaluated by a core laboratory. Patients were randomized to an invasive strategy of optimal medical therapy with either revascularization with bypass or CABG or PCI versus medical therapy alone. The primary endpoint, as you can see, was cardiovascular death, non-fatal MI, hospitalization for unstable angina, heart failure, or cardiac arrest. And there were other major secondary endpoints. And I can tell you the endpoints in this trial varied and were changed as time went along due to the poor enrollment in this particular study. Inclusion criteria: patients had to have ischemia, and so they had to have more than a 10% ischemic defect by myocardial perfusion imaging. They had to have more than 3 ischemic segments by echo, and etc. Also by CMR, more than 12% ischemia based on wall motion abnormalities. And also by treadmill testing, criteria were very strict in terms of ischemia. Importantly, this patient did not include people with advanced kidney disease, ACS, unprotected left main, unacceptable angina, like Canadian Heart Association class 3 or 4, heart failure, or low EF. So you can see this is a very, very select population. And you can see in terms of the enrollment, you can see the exclusion criteria here. And this final group of 5,000 was selected from some 26,000 patients who were screened. So a very small minority of the screened population actually ended up in this trial. And the statistics were based on a power of 83% to detect an 18.5% relative reduction in events with revascularization versus optimal medical therapy. I want to emphasize again that although functional testing and anatomic imaging results were used as an entry criteria, imaging was not considered a primary, secondary, tertiary, or any other as part of a study endpoint. And this is important because there's a lot of people discussing the value of imaging and whether imaging is really important in this day and age based on this trial. If you look at the mean age, it was in the 60s. If you look at diabetics, about 40% were diabetics. If you look at patients with prior MI, about 19% and about 20 to 30% with prior revascularization. But importantly, these patients had good ejection fractions. Most of these patients had moderate to severe ischemia by all techniques, whether you look at nuclear, echo, CMR, or exercise stress treadmill testing. And the majority of patients in this trial actually had nuclear imaging as the assessment, with about 50% having myocardial perfusion imaging. About 2/3 had multivessel disease. But what's interesting is that if you look at monthly angina or no angina, that represented the majority of the patients. So most of these patients really had minimal angina, despite the fact that they had ischemia. And in fact, most of these patients either had no angina or, in Canadian Cardiovascular Society, angina class 1 or 2 the month before they got enrolled. Okay? So a lot of ischemia maybe, but not a lot of symptoms. And again, a good EF. Let's look at the therapy in this study. Very high intensity statin therapy when you look at baseline versus last visit. 60% of patients on high intensity statins, 24% with ezetimibe added on, as well as other medications. And when you look at beta blockers, calcium channel blockers, and other anti-anginal ischemic medications prevalent in both limbs, both the revascularization limb and the medical therapy limb. Only dual antiplatelet therapy was greater in the revascularization limb, which ended at about 18 months, which is reasonable based on current information. When you look at medical interventions, blood pressure was well controlled. Statin therapy was used, and in fact, if you look at baseline versus last visit, total cholesterol levels went down to 130. LDL levels went down to 60. So this was really optimal medical therapy. And in fact, there was good control of hemoglobin A1Cs, and patients also stopped smoking. In the revascularization group, by angiography, most patients had ischemia. And importantly, treatment was very up standard of care, using mostly second-generation stents, drug-eluting stents, and also bypass surgery in about a quarter of the population, with the internal mammary artery used in most patients. So very good therapy. And you can see that the randomization was reasonable. Most patients had revascularization in the invasive therapy group, and only 13% in the conservative therapy group at the 1-year time period, although it went up to about 20% by the 5-year time period. So the primary outcome, no difference. And in fact, when you look at 6 months or out to 4 years, no difference. If you look at one variable, the restricted mean end freedom time, patients had an event 9 days later with revascularization than did with medical therapy, okay? But again, not significant. And so the ischemia trial does not show a difference in event rates with medical therapy versus revascularization. But the ischemia trial does not negate the importance of identifying and aggressively treating myocardial ischemia. But it does demonstrate that this can be accomplished either through aggressive anti-ischemic medical therapy alone or in conjunction with coronary revascularization. And this was also shown true for death from any cause and also death from cardiovascular causes. Of interest, there was some interest in terms of reduction in angina, and what we do see is that in patients who did have angina to begin with, that the invasive therapy group, particularly out at 36 months, showed better reduction in angina. So at 36 months in patients with a Seattle angina score that was low, like 10 or 20, which indicates a lot of angina, only about 20% of patients were angina-free in the conservative treatment group versus 60% in the revascularization group. But in patients with high Seattle angina questionnaire scores, let's say of over 75, where there was very minimal or no angina to begin with, you can see that when you don't have angina, revascularization doesn't improve your ability not to have angina. Okay, and medical therapy does as well. So I guess the one take-home message from ischemia trial is that, yes, revascularization can reduce angina in people who have at least moderate angina. So, in conclusion, we have the importance of seeing really the big picture here. The ischemia trial confirms prior studies of medical versus revascularization strategies, but again in a select group with moderate or severe ischemia, and importantly, in patients who have normal EF and who also don't have high-grade anatomies such as left main disease. What are some of the caveats? The ischemia trial was not an imaging trial, although imaging did define the population, and it was not designed to determine the relative value of CTA versus functional testing as suggested by some. There are still unanswered questions. It's unclear whether baseline ischemic perfusion defects alter the results. It is unclear whether the results differ or will differ based on the type of revascularization. It's unclear what percentage of patients were not enrolled due to physician concern over randomization. In other words, did patients with large ischemic defects who were more symptomatic just not get enrolled in ischemia because everyone had the preconceived bias that revascularization would be better? And we clearly need longer follow-up because there may be some divergence in the curves already at that 2.5-year endpoint, and we really need to see at 4 and 5 and 8 and 10 years, hopefully, whether that continues to diverge in favor of revascularization. So where do we stand? We're still navigating across alien terrain, but the landscape, I think, is becoming more familiar. Where do we stand in terms of the ischemia trial? I think functional testing in terms of SPECT and PET in particular will continue to be front line for stratifying risk post-MI, evaluating symptomatic patients with known disease, and those with high-risk features, such as those with suspected coronary disease or high risk because of risk factors, or those with known coronary disease with depressed left ventricular function. I think CTA will continue to grow as a means of testing people who are symptomatic, particularly in lower risk populations, to either exclude or identify plaque, and also as a secondary test to exclude CAD in patients with equivocal functional tests or those with normal test results or still have ongoing symptoms. I think stress MPI will continue to be viable in patients with intermediate risk with suspected coronary disease, and in terms of particularly using potentially calcium scoring to define both short-term risk and long-term risk using anatomic and functional testing. And in terms of the ischemia trial, I think the ischemia trial basically tells us that patients maybe revascularization can be deferred in patients with moderate ischemia, depending on their symptomatology, with the idea of potentially doing, in patients who don't want to get revascularized, doing CT to exclude at least left main disease as an option. And I thank you for your attention, and thank you very much.
All right. Well, very good, John. Excellent presentation, and we've now got some time for some questions.
Sure.
We've got some from that people have texted in. If we also have any questions from anybody in the audience here at Houston Methodist, virtual audience, I should say, we'd be glad to take those as well.
John, can you hear me?
Yes.
Hi, Bill Zarbi here. A great presentation, really going through memory lane and putting the whole perspective of coronary disease, even the asymptomatic and the symptomatic individuals, and the role of each, calcium scoring, stress testing, and everything else. I like the points that you emphasized regarding the ischemia trial, because number one, it is the one that is most visible now, and remembering two things probably. One is the exclusion criteria, which are important, meaning an AF of less than 35%, kidney disease, et cetera, et cetera. So I think we have to remind ourselves of these exclusion criteria. And putting this trial together with STITCH trial, which emphasized more on the depressed ventricular function So I can see these two as continuums of a depressed ventricular function, et cetera, particularly the diabetic patients with the FREEDOM trial. So trying to look at all of it together, and also remembering that at 4 years, you have about a 20% crossover of patients that became more and more symptomatic. So yes, we have a great option in medical therapy, and also remembering that this is very aggressive medical therapy for people. We're trying to treat patients with moderate or large ischemia with aggressive statin therapy, antiplatelets, everything else, and anti-ischemic drugs. So I just few points to emphasize again, a great presentation that you did. Thank you, John.
Thank you. You know, Bill, I really totally agree with you. I think we do have to look at what trials have shown us over the years. And I think for left main disease, which was excluded in ischemia trial, in people with depressed LV function, clearly we know that those patients do better with bypass surgery versus medical therapy alone. But I do want to say also that there are data to show that statin therapy actually preserves graft patency in people who get bypassed. So it doesn't exclude the need for medical therapy. It's just that some populations benefit most from revascularization on top of aggressive medical therapy. The other thing I want to emphasize is that what the point you brought up, that where you make a decision tree in terms of should I do interventions immediately or should I hold off, that yes, there are going to be crossovers. And just because someone crosses over from medical therapy to revascularization, I don't look at that as a failure. I think we can't say just because you're on medical therapy that you must always stay on medical therapy alone. We always have the option to revascularize if patients change over time. And that's one of the beautiful things about clinical medicine, is that we can treat patients over time on a continuum and be able to reassess how patients are doing in order to optimize outcomes.
There's always disease progression. I think what I like about the endpoints of the trial, and these are spontaneous events, meaning that the spontaneous events were held at bay, but the progression of disease, at least from a symptoms point of view, requiring revascularization, has occurred and it will occur, hopefully not taxing the outcome.
Right, and I want to also make one comment about FAME 2, because, and I tried to emphasize that quickly in my discussion, but if you look at urgent revascularization, that was the only endpoint where medical therapy did worse than revascularization. But when you look at death, at the death curves, or you look at the non-fatal MI curves, it's not as though they all of a sudden go up in medical therapy concordant with the increase in quote-unquote urgent revascularization, which would indicate to me that these are patients that came in simply with worsening angina, who then were treated, and did not have concurrent myocardial infarction or a worse outcome because they hadn't been revascularized to begin with.
John, we've got one question from the somebody texted in, which is, I didn't hear anything about heart flow. Is there any value in that? Now,
Okay.
obviously, the ischemia trial didn't include CT-FFR because, again, this is a technology that's too new.
That's
But
correct.
give us some...
So I think FFR by CT is still in evolution. And I can tell you that there's actually a fair amount of discrepancy in FFR results by CT versus invasive FFR results that we see in the cath lab. And you have to remember that FFR CT is still defined by anatomic constructs rather than invasive FFR, which is really a physiologic assessment, okay? And when you look, for instance, at FFRs between, let's say, 0.7 and 0.9, where actually most patients sit, okay, that's where you get the greatest discrepancy between what you see in the cath lab and what you see with CT. And in fact, between 0.7 and 0.9, you might as well flip a coin in terms of if you have positivity by CT, whether it will be positive in the cath lab, or if you have negative by CT, whether it will be negative in the cath lab. So I think over time, maybe we'll get better refinements with these kind of measurements, but FFR, I still think, has not reached prime time. And the other thing that's important to recognize about FFR-CT is that there are a lot of patients who are not candidates, such as those who have prior bypass surgery, prior angioplasty, patients with severe calcification are problematic, and patients who have any kind of motion or suboptimal CT scans cannot be assessed. So a very limited population in terms of who we can assess.
All right. Well, very good. I want to thank you, John, for outstanding presentation, and I want to thank the audience for tuning in, and we'll see you all again here next week.
Great. Thank you very much.
Good job.